answer them.
Here is Shingi. Our presenter is Shingi Malai. Shingi received her doctorate of pharmacy degree from Massachusetts College of Pharmacy and Health Sciences, Boston, Massachusetts. She is a member of the American Society of Consultant Pharmacists, American Pharmacists Association, Rokai Pharmacy Honor Society, and volunteers as a field tester for the BCGP recertification activities. She is a board certified geriatric pharmacist and is recognized as an age-friendly pharmacist. She has worked at Guardian Pharmacy in Maine for 10 years and is passionate about helping students to grow and succeed. And she also serves as a preceptor for pharmacy students. Welcome, Shingi, to your today, and we are looking forward to your presentation. I did want to just make note, just like the last presentation, if you have any questions, please put them either in the Q&A or you can put them in the chat box, and we will go over questions at the very end. Okay, Shingi, your turn.
Thank you. Hello. Good afternoon, everyone. Thank you so much for coming. We're having a rainy day here in Maine, so I hope your weather's a lot better. So yes, I will be talking to you today about psychotropic medication use in dementia and improving gradual dose reduction success. And I have no disclosures. So we're going to take a journey together, and I hope so. Buckle up. And we'll start with what dementia is, and then move on to the symptoms of Alzheimer's disease. We'll also discuss the role of psychotropics in dementia and explain the challenges associated with the use of psychotropic medication in dementia. We'll also list some examples of improving gradual dose reductions in your facilities as well. So this is a topic that is very dear and near to my heart, not just because of the work that I do as a consultant pharmacist, but unfortunately, I also lost a very close family member in the last couple of years to end-stage dementia. And in 2020, the CDC reported that almost 46% of all residents living in long-term care facilities are living with dementia. So given this, it is likely that many of you, like me, have firsthand experience with the unique challenges involved in caring for someone with this condition, whether personally, through family members, or through our work. So what is dementia? So you can look at it, sometimes people get confused about what dementia means. In everyday conversations, when we use the term dementia, we're often actually talking about Alzheimer's disease. However, Alzheimer's is just one of the conditions that can lead to dementia. And I did highlight it in red on the slide because Alzheimer's is the most common cause of dementia, and 60 to 80% of cases are from Alzheimer's disease. So imagine dementia as a big umbrella covering a variety of conditions and diseases that cause the brain cells to break down faster with normal aging than normal aging would over time. And then this breakdown causes a gradual decline in cognitive abilities. And when we talk about cognitive decline, we're referring to the deterioration of important abilities like memory, language, or problem solving, and also some psychological symptoms as well. It also includes a gradual loss of ability to carry out day-to-day activities of daily living. And then I also just want to mention that Alzheimer's disease is the most common cause of dementia, but it can coexist with other conditions like Lewy body dementia or vascular dementia. So what about the prevalence of the disease? What is its impact on society? And this slide focuses on the prevalence. Globally, the World Health Organization ranks it as the seventh leading cause of death worldwide. And I was actually surprised when I read it, because I would have thought, infectious diseases, COVID, cardiovascular illness would be ranking high, but it's seventh in the world. And then looking at Alzheimer's specifically being the leading cause of dementia, in 2024, almost 7 million Americans aged 65 and older were living with Alzheimer's disease. So that comes to 1 in 9 people. So it has quite a huge impact on our society. So let's look at Alzheimer's disease progression in particular. While no one can predict exactly how Alzheimer's will unfold for a person, it can be helpful to learn what you can generally expect. There are some preclinical stages to the disease, such as mild cognitive impairment, and it's important to note sometimes that not all cases of mild cognitive impairment will progress to dementia. So this infographic gives a general overview of the 3 main stages. Memory impairment is the most common initial one. That's what you usually start seeing first, that memory impairment. And then during that mild stage, a person may actually function independently, but you may notice difficulties with language, such as coming up with the right words. They'll say, instead of cousin, somebody might say, oh, your brother's child, or they have difficulty finding that right word, and forgetfulness. And then also executive function difficulties, such as planning and organizing. And you may see there's frequent losing or misplacing of belongings. And progression through the stages is gradual. And then during that middle stage, that moderate stage, the memory loss continues to progress. And the person living with Alzheimer's may need some assistance with daily activities of living, such as personal care and hygiene and grooming. And just the complex everyday tasks become more and more challenging during that. And we may also see some mood and personality changes as well, such as depression, anxiety, and some irritability as well. And sometimes, unfortunately, even delusions and hallucinations, hearing and seeing things that are not there. And then in that advanced late stage of Alzheimer's, that's when people often need care around the clock. And you'll see changes in their physical abilities, loss of mobility, so ability to walk, some swallowing difficulty. That's when often you have to lean in on your consultant pharmacist for help with switching from tablets, or which ones can be crushed and cannot be crushed. And during this stage, that's when often you may have to consider palliative care or hospice consults, and you see a real worsening in those neuropsychiatric symptoms. So we will have our first poll. So which disease is the most common cause of dementia in older adults? I'm just checking in how everyone's doing so far, and I'll give you a moment to answer this question. Is it A, dementia due to Parkinson's disease? Is it B, frontotemporal dementia? Is it C, vascular dementia? Or is it Alzheimer's disease? Great. That's awesome. So 75% got it right. It is Alzheimer's disease. Vascular dementia is the second most common one, and Lewy body is the third most common one, but the correct answer is Alzheimer's. 60 to 80% of all cases of dementia are due to Alzheimer's disease. So you did a great job. I usually give prizes, but because we're online, I can't give any prizes to those who got the answer right. So this slide, we're continuing on our journey, and this slide is looking at the pharmacological or drug treatments. And this infographic gives you a quick overview of the place that psychotropic medications have in dementia treatment. So overall, The typical progression is a slow, steady decline, and generally the way dementia is treated depends on its cause and stage of the disease. So the disease modifying treatments, they are the monoclonal antibody targeted therapies. That's a mouthful. And they are intravenous infusions that are used in the early stages of the disease to slow its progression. They are also called disease modifying agents. However, they cannot stop or reverse the disease. They can only slow its progression. And then going down to the bottom left or right, the bottom left for me, the acetylcholine esterase inhibitors and NMDA inhibitors, which would be the memantine, they help to manage symptoms related to cognitive function and ability to function in everyday life. And I'm sure you've seen donepezil many times on your drug charts in your facility. So we will be focusing on those psychotropic medications, which help with the behavioral and psychological symptoms that may arise as the disease progresses. So what is the role of psychotropics in dementia? Let's dive into those psychotropic agents. So a psychotropic drug, you may also have heard it referred to as a psychoactive, and often will interchange the two words psychotropic and psychoactive. It's the same thing. And I want to point out that there are many other drugs that work indirectly on the brain, such as blood pressure medications or medications used to treat epilepsy. However, we're going to focus on those drugs that work directly on neurotransmitters in the brain to help manage aspects such as mood and sleep or anxiety. So psychotropics are specifically designed to influence brain chemistry. And the ones most frequently used for our geriatric older adults are the ones on the screen, and they include the antidepressants, the anti-anxiety, the antipsychotics, and then the sedative hypnotics that help with sleep. So there are two main things that we need to know. There's the clinical consideration, and then we also need to understand the regulatory guidelines. So we'll start with the clinical considerations. When starting a psychotropic medication for dementia, this should include reviewing the resident's current drug therapy. We look at the pharmacodynamics and pharmacokinetics of the drug, and those are just fancy terms for saying this is what the drug does to the body, and then how does the body handle the drug. Are any other of their medications causing the symptoms? Is anything new or has anything changed? And in the pharmacy world, there are tools that we use, such as the Beers criteria or the stop-start criteria, and they help to provide guidance on which medications are potentially inappropriate for the older adults, and also which ones to avoid for certain disease states and any clinically significant drug interactions in older adults. Most importantly, the medications should only be used when non-pharmacological treatments have been unsuccessful and symptoms are severe, persistent, and ongoing. Ideally, a comprehensive evaluation should be conducted to identify any underlying conditions. For example, it could be a B12 deficiency or it could be hypothyroidism. And all these factors need to be considered when establishing treatment goals. And then tailor the medication to the target behaviors. And just on a side note, documentation of target behaviors should not be seen as the diagnoses for using the medication. So rather, target behaviors are the undesirable behaviors that occur as a result of a diagnosed medical condition. And often you'll see us as consultant pharmacists will write up a recommendation asking for clarification on a diagnosis when a psychotropic agent is started, because on the drug chart it says quetiapine for aggression, but that's not the actual medical condition. And an example of tailoring medication to target behaviors is when a resident is suffering from anxiety symptoms, but doesn't have any psychotic symptoms like delusions or hallucinations. So starting an antipsychotic might be seen as inappropriate. Rather, treatment should be with an agent that addresses the underlying symptoms of the anxiety. And then keeping track of those behaviors is important, both in numbers and details, and any adverse effects, as this also helps us to see how well we're doing with working toward our treatment goals. And then finally, the second piece is understanding the regulatory guidelines, and we'll touch on the regulations briefly later in the presentation. So we'll start off with the antidepressants. So they are not only used for low mood depressive symptoms that you see listed here, such as low energy or worry or sadness. They are sometimes also used for anxiety and dementia-related agitation symptoms, although that would be an off-label use. Which leads us to our next poll before we continue. So, which of the following examples of documentation could help to demonstrate that you've done a thorough assessment to justify the use of psychotropic treatment, such as an antidepressant? Would it be A, you documenting the specific diagnosis and any target behaviors? Would it be B, any non-pharmacological interventions that you've tried? Would it be you documenting symptoms adversely affecting quality of life, or would it be all of the above? I'll give you a moment to answer. Great. Yay, 97%. All of the above. It is all of the above. So a good comprehensive note that covers you would cover all of those four things that are mentioned above. Great. You're doing so well. So this slide shows the most common antidepressant classes that you may see in practice. The first-line agents are the selective serotonin reuptake inhibitors, and that's a mouthful, so I'll refer to them as SSRIs going forward. Sertraline, escitalopram, and citalopram are the ones that are usually the first-line agents within that drug class. There is another group called the monoamine oxidase inhibitors. And these you won't generally see much of, you'll rarely see. They are usually initiated by psychiatrists. They have awful drug interactions and side effects that have to be monitored. And this table gives a little bit more detail. The higher the number of check marks indicates increased severity of side effects. So it is not a comprehensive list of all antidepressants, but I've narrowed down to those that we most commonly see in practice. And one key thing that sets them apart within their drug classes is their side effect profile. And this table sort of, as I mentioned, gives a general overview of those different side effects. And this can help us when knowing which ones to choose or avoid for a specific patient. So even though the SSRIs are the first-line agents, there are differences between them, and I'll point out a few. Generally, we try to avoid paroxetine and fluoxetine. Paroxetine has the highest anticholinergic burden, and this means that it has more adverse effects with respect to confusion, falls, and worsening cognition. It also has a short half-life, and so in situations of missed doses, if the resident refuses their medications, then it has a higher risk of withdrawal symptoms to occur. Fluoxetine has a long half-life, and it takes a long time for the drug to leave the body. That's what that means, which means side effects may linger for longer. It also has more drug interactions than other agents. And it can be quite activating, as you can see here. So it can cause increased anxiety and agitation. And citalopram, even though it's one of the preferred choices, we just have to be careful with it because of its cardiovascular side effects. It can cause what we call prolonged QT interval, which can lead to irregular heart rhythms, and so may not be a good choice for someone with cardiac disease. Duloxetine and venlafaxine have not been well studied in dementia and can have unwanted effects on the heart, um, such as increased blood pressure. However, they may help with pain and so are useful for when patients have neuropathic pain together with depression. And then we generally avoid those tricycle antidepressants such as amitriptyline because of increased adverse effects, particularly in the geriatric population, such as increased confusion and risk for falls. Trazodone, as you can see, one of its biggest side effects is drowsiness, but we often use that side effect to help those with depression and trouble sleeping. And then mirtazapine can cause weight gain. So it's often used for those with weight loss or who are underweight, as it may help to increase weight and also helps with sleep. So the goal is to enhance overall quality of life. And let's look at the gradual dose reduction now for antidepressants from a clinical point of view. So firstly, we need to know that it's good to try dose reduction, but it may increase the risk for relapse, especially within the first 6 months. And we want to avoid abrupt disruption because this can cause what's antidepressant discontinuation syndrome, and it can manifest with symptoms such as insomnia, fatigue, or achiness. And so for this reason, actually, detailed behavioral monitoring is critical during any dose reductions to monitor for symptoms of withdrawal or relapse. And we want to see information on numbers of behaviors and description of the behaviors. If the withdrawal symptoms do occur, they usually happen within a few days if the antidepressant has been tapered too quickly or stopped too abruptly. So overall, the key takeaway is when attempting a gradual dose reduction for an antidepressant, a slow taper is best practice with close monitoring for symptoms of relapse. And now we'll move on to the benzodiazepines. These are not recommended for behavioral symptoms of dementia because the adverse effects associated with them often significantly outweigh any potential benefits. However, in practice, we do see them commonly prescribed for older adults. They should really only be used to get through an acute, brief, stressful period of crisis or for debilitating anxiety. So one way of recognizing benzodiazepines on a drug chart is by looking at the ending of its name. Most of them end in PAM or LAM, so the PAMs or LAMs. And the reason why benzodiazepines should not routinely be used for dementia symptoms is because in older adults, they have increased sensitivity to benzodiazepines. And so they'll be more susceptible to their side effects, like the sleepiness and the drowsiness, the sedation. And then this can lead to falls and broken bones and hip fractures. They can also precipitate delirium and confusion and can worsen cognitive function as well. So in a nutshell, we may actually end up worsening the cognitive symptoms of dementia by using these benzodiazepines. If a benzodiazepine must be used, then clonazepam and diazepam should be avoided due to their long half-life, meaning they take longer for the body to clear, especially in older adults. And you can see for diazepam, it's up to 100 hours. This can lead to, that longer half-life can lead to really lingering effects and adverse reactions that can really be quite debilitating. And then when comparing the lorazepam and alprazolam, it's best to lean towards lorazepam. You probably do see it in practice that lorazepam is used more, and it's because of the onset of action. Alprazolam has a faster onset of action, as you can see, 15 to 30 minutes, so it can create feelings of euphoria and increases the risk of dependence. So the goal is to maintain optimal level of function and improve the quality of life. And how about the gradual dose reduction? How do we taper benzodiazepines? So an example of a taper schedule is one proposed on the deprescribing.org website. And in my list of references, I have it listed there if you're not familiar with it and want to go in there and see that resource. And it's a useful resource for providing guidance on how to reduce or stop medications in a safe way. They recommend aiming for very slow incremental reductions, no more frequently than 25% every 2 weeks. An alternative is a 50% reduction initially, and then incorporate some drug-free days towards the end of the taper. And then all of this is to help to avoid any withdrawal symptoms, such as anxiety or irritability, GI symptoms, and insomnia. And I think this brings us to our next poll. So given that certain benzodiazepines have a longer half-life and take more time to be removed from the body, which of the following two drugs poses a greater risk of potential harm in an older adult with dementia? Is it A, diazepam, or is it B, lorazepam? Oh, I made it easy this time. I only gave you two choices. Yes, correct answer. 91% got it right because of the long half-life. Exactly, diazepam is the correct answer there. It would cause greater risk and potential harm. It lingers in the body, so the person may continue to experience those adverse side effects for much longer. So now we move on to the antipsychotics. So they are often used off-label for the treatment of neuropsychiatric symptoms in dementia. So these would be symptoms of psychosis, delusions, hallucinations, agitation. And we call it an off-label use because the FDA has not approved them for treating this condition. Brexpiprazole is the only FDA agent for agitation associated with dementia in Alzheimer's disease. Another one you may have heard of is pimavanserin, and that one has FDA approval for Parkinson's disease psychosis. Antipsychotics come with a black box warning, and this is the strongest type of safety alert because they can raise the risk of death, stroke, and heart attacks in older adults with dementia-related psychosis. So really serious side effects there. As you know, the non-pharmacological measures should always be used first line. We should only use antipsychotics in situations when symptoms are severe with risk of harm or are dangerous and or causing significant distress to the patient and others. I mentioned the Beers criteria earlier. They're included in the Beers criteria, recommending that they should be avoided whenever possible as being potentially inappropriate medications in the geriatric population. And if an antipsychotic has to be started, then we start low and we go slow. So early in the presentation, I talked about importance of being specific with naming target behaviors. So this slide shows how the term agitation can be used to describe a range of behaviors. And we should be, as much as possible, we should try as much as possible to avoid listing agitation as a target behavior for monitoring. The International Psychogeriatric Association developed a consensus definition of agitation in patients with cognitive behaviors. And in their definition, they list three categories of behaviors. So verbal aggression, excessive motor activity, and physical aggression. And then on a side note, there are objective rating scales that can be used to measure agitation. That CMAI is the Cohen-Mansfield Agitation Inventory, and the NPI is that one can be used for caregivers. Caregivers can use that one, or the NPI, which is the Neuropsychiatric Inventory Rating Scale, can be used by a clinician. So you can see on the slide that agitation can manifest in behaviors that do not involve aggression, such as repetitive gestures, pacing, or wandering. So if a resident is prescribed an antipsychotic and care staff are asked to describe the patient's behaviors by a state surveyor, for example, they might report wandering or pacing. However, if there's no aggression or danger to themselves or others, and no alternative redirection measures have been tried, prescribing an antipsychotic might be considered inappropriate. And I mention this as an example of how the term agitation can be an easy target for scrutiny when it comes to prescribing antipsychotics due to concerns about inappropriate use. So the key takeaway is to always try to document the target behaviors in a way that is clear and unambiguous to anyone monitoring the resident. So this table shows us how we can use drug characteristics for product selection and also for developing a plan for monitoring adverse effects. So postural hypotension or low blood pressure and falls are side effects of all the antipsychotics. We would want to monitor for blood pressure at least monthly. Extrapyramidal side effects are really terrible movement disorders that can happen when someone takes an antipsychotic drug. They are involuntary movements which may involve tremors or jerky limb movements. And this is why part of your monitoring plan should include an abnormal involuntary movement scale. And I'm sure some of you are familiar with it. The acronym is AIMS, AIMS. And the recommendation is that this should be done every 6 months. And then with respect to which antipsychotic, let's look at olanzapine. You can see it has the highest risk for adverse effects from amongst the selection of drugs in terms of drowsiness or sedation, hypotension, those unpleasant extrapyramidal side effects, the movement disorders, weight gain, the increased risk for diabetes. And so it's generally not one that we use first line in older adults. That's why you probably don't see much of that one. When comparing quetiapine and risperidone, those are two antipsychotics which we see most commonly prescribed in practice. The risperidone has a higher risk than quetiapine for the extrapyramidal side effects. And so for a patient that may have Lewy body dementia, for example, that has some aspects of movement disorder, quetiapine would be a better choice. Monitoring for effectiveness and side effects is vital for antipsychotics. Include the number and description of episodes. For example, document 4 episodes of biting and hitting versus a documentation that reads agitation all day. And the documentation ideally should happen at every shift. And your consultant pharmacist can be a great help in helping you to design a monitoring plan for side effects. If you suspect an adverse reaction to a drug has occurred, be sure to document the actions taken to address these adverse effects. So what are our goals of treatment with these antipsychotics? So it's to make sure that the resident has the best possible quality of life. We're keeping an eye on how well the drug is working. Have their distressing behaviors eased? Are they experiencing any side effects? And then in terms of gradual dose reduction, from a clinical perspective, the American Psychiatric Association guideline for treatment of dementias recommends that if there's no meaningful improvement after 4 weeks, then really we should be thinking about a gradual dose reduction. But if the medication is working well, even then, even if it's working well, we should still start thinking about tapering within the first 4 months of using it. And always avoid just an abrupt discontinuation. This helps to prevent, not stopping it abruptly will help you to prevent withdrawal issues like worsening psychosis or delusions or aggression. And unfortunately, there's no one size fits all for tapering of antipsychotics, but tools like you can find on deprescribing.org and MedStopper can offer some helpful guidance. And then now, so what do the regulations say about psychotropics? So the medical record must include documentation supporting the diagnosis. There's an emphasis on the resident's right to consent, especially when initiating or increasing the psychotropic medication, and also about informing the patient or their representative about the risks and the benefits, and that other alternatives have been considered, and the antipsychotic is really the only choice. You can the documented verbal consent is sufficient, but just be sure that that documentation has covered everything that was reviewed verbally. And then residents who use, so unless really there is clinical improvement, we should really try to be tapering off the antipsychotic and starting the gradual dose reductions. And I think I've said this several times already, the non-pharmacological interventions are always important to try those first, and only use the psychotropic if they have failed. So based on our discussion so far, it is evident that from both the clinical and regulatory perspective, a thorough evaluation or workup is best practice, especially when in situations where it's not an acute emergency situation. And this will help us to determine and be able to document appropriately the appropriateness of initiating a psychotropic agent. And this would include, for example, lab work to rule out any underlying causes such as a B12 deficiency or anything like that. And even trying to identify the type of dementia would be helpful, because some of them have different ways of being treated. Alzheimer's or Lewy body, you would have different approaches, or frontotemporal. And this will really help to determine which treatment to initiate. And then we need to document that the resident and representative have been informed of any proposed changes, and also that they've been told of the risks and the benefits, and they've consented, and document all of this. And I'm sure you've heard many times in your communities, if it's not documented, it didn't happen. And then once we start the psychotropic agent, at some point, we need to slowly lower the dose over time. And like we've discussed, this tapering is important for both clinical reasons and also for the regulatory requirement as well. And I think this leads us to our next poll. So take a moment to think about this check-in question and share your thoughts on what you think is the best answer. For which of the following behaviors might giving someone an antipsychotic be considered a chemical restraint? Is it A, pacing, B, if they're having repetitive mannerisms? Is it C, resistance to care without aggression? Or is it D, all of the above? Yes, 90% of you put all of the above. That is so right. If the resident is pacing and wandering, but they're not causing any danger to themselves or to those around them, that could be considered an inappropriate use of an antipsychotic, or repetitive mannerisms or gesturing. So yes, 90% of you had answered that correctly. Great. So now we will dive into the final section on the gradual dose reduction strategies for success. So we'll start off with, what is a gradual dose reduction? So the CMS definition states it's a stepwise tapering of a dose to help us see if symptoms or conditions can be managed with a lower dose or if the medication can be stopped altogether. So residents taking, so that's the definition. And basically all residents taking psychotropic medications should have their doses gradually reduced and also receive behavioral interventions unless there's a clinical reason not to. So identifying and addressing any barriers is essential for setting yourself up for success with your gradual dose reduction endeavors. And I've listed some of the barriers here. And some of them are obvious: lack of resources, lack of staff educations. And some of them, one of them includes a situation when a specialist has initiated a psychotropic agent, and then sometimes you might hit a barrier when the facility clinicians are reluctant to review it or change doses because they're not the ones who started the medication and are sort of reluctant to. And then another one is absence of a standardized process. So here in Maine, an expert group of stakeholders a couple of years ago, which included also the Medical Directors Association, they came together to develop some key strategies aimed at improving patient-centered dementia care in Maine's nursing homes, and with a specific focus on reducing antipsychotic use. And they emphasized that it's really important to set clear guidelines and principles to highlight why gradual dose reductions matter. So one of the things you could do is to create a gradual dose reduction facility policy. And that would also allow you to be able to individualize your strategy to your facility and also ensure that the current practice is in alignment with regulations. And then it could even also be used for internal evaluation of compliance with best practice. And I put just an example one up on the screen. Secondly, establishing a therapeutic environment. And this slide includes a snippet of a Story of My Life booklet. And some facilities will include life story questionnaires in their admission packet to help us understand the resident better. Because knowing someone's life story can give us a knowledge of who they are at their core, what brought them joy and purpose to their life, and what their dislikes and fears are, so that we can help to create a personalized intervention. And then this might help to reduce the need for psychotropic medications and facilitate successful GDRs. And use your data. So as consultant pharmacists, one of our key responsibilities is to monitor and report on psychotropic medication use within the facility, and then analyzing this data alongside your minimum data sets, your MDS information, will allow you for an objective assessment. For example, which psychotropic medications are being used most frequently in your facility, and for which residents, and for what clinical indications. And so you'll be able to identify trends and target areas where gradual dose reductions may be appropriate. And then this will help to support your regulatory compliance and that patient-centered care that we discussed in the previous slide. And then staff education. As you know, great dementia care starts with strong skills and a real understanding of the condition. So one suggestion is to identify or to professionally develop a staff member to become an expert in dementia care. And then they can act sort of as a coach or a champion for the rest of the team and work alongside them, sort of formally, and give informal and formal training and support. And then they can help your team to build confidence and skills in key areas, like with de-escalating behavioral issues. And this would hopefully reduce the need for starting a psychotropic medication, and also support those who are being tapered off them. And then transitions of care. Whenever possible, it is important to clearly communicate any specific patient-related needs Even when we think of our life stories, if there's any quirkiness or anything for that particular resident, to let the hospital know in the transfer form to support a smoother transition. As you know, transfers to hospital can really cause significant distress for patients living with dementia when they depend on familiarity to feel secure. And then when a patient is readmitted or it's a new admission with a psychotropic medication, if there's no clear reason documented, an assessment should be done to determine whether continuing the medication is appropriate and if a GDR can be initiated. It could have been started in hospital for an acute episode of delirium, for example, and now the resident is back at home in the facility and they're stable, and it could be weaned off through gradual dose reduction. And then don't forget the family and caregivers. Share helpful resources to educate them about psychotropic medications and why gradual dose reductions matter. The hope is that once they understand the risks of psychotropic agents, it might help to overcome, hopefully, any resistance to medication changes that are needed. And I just wanted to mention that currently there is a movement to create age-friendly health systems across the nation with a goal to create health systems that ensure every older adult receives the best possible care. And this framework brings focus to four key elements: what matters, medication, mentation, and mobility. And incorporating the four M's into the care approach for residents living with dementia may also help to enhance your efforts with your gradual dose reductions. And I know there will be another talk on the four M's in this symposium. And then implementing now the gradual dose reduction should be a collaborative process. And it's the seventh step because ideally the earlier steps need to have been put in place to help set the stage for a smoother and more successful dose reduction once it's time to start one. And the best thing is team effort, where everyone in the interdisciplinary group is involved, from your consultant pharmacist to the social worker and CNA staff. And some facilities where I work have psychotropic groups where we meet and discuss certain residents and sort of come together, and the medical director's there, and director of nursing and a social worker, and then always ensure adequate documentation. So document the date of the GDR, the outcome of the dose reduction, and the plan regarding any future GDR attempts. And I mention this because sometimes you'll have done all the great work in doing it, but it's actually hard to retrieve that information. So make sure everyone in the team knows where to find your gradual dose reduction information. Is it in the medical notes? Are you relying on your consultant pharmacist notes? So they're easily retrievable. Your consultant pharmacist can help you create a GDR tracking system, and that will help you to show your progress and keep record of your work. And it's a great way to celebrate any success as well and keep everyone motivated with your GDR strategies. I also want to mention the DICE approach. It's an easy to follow structured way to assess and manage behavioral and psychological symptoms in dementia. And this approach can be especially valuable in supporting patient comfort during a gradual dose reduction. And then it also helps to ensure that any signs of relapse are not mistakenly attributed to the tapering process, and when it's really rather through other contributing factors. So you'll think the GDR has failed, but it was actually something else that was causing what looked like relapse. So describe the stressful or problematic symptom. Investigate, could the symptoms be due to an unmet need, a medical need, a sensory issue like vision or hearing, or could it be as simple as caffeine? Is that resident, they love their coffee and they're having a cup of tea or coffee at 5 o'clock, late during the day, and now it's affecting their ability to sleep? And then create a plan. Do you need to make an appointment for a hearing assessment? Is it boredom? So then encourage activities that match the residents' interests, and using those life stories can help. And then evaluate effectiveness of the interventions. So some clinical trials have shown that music therapy may help reduce symptoms like aggression, agitation, and wandering without having to start psychotropic agents. So we'll try a quick experiment. I want you to experience firsthand the powerful impact that music can have on mood. This first song is really loud, so you might want to turn your volume down. So here we go. And then here's the second one. So I don't know how those songs made you feel, but personally, that first one made me feel kind of agitated and unsettled. And the second one was more peaceful. It's like almost brings you calm. And I've included on this slide the website for the Music and Memory Foundation. So I encourage you to go on there and see music therapy in action. And then engage your medical director. And this slide has an image of an orchestra director. The work of the medical directors is a lot like an orchestra, overseeing a diverse range of healthcare professionals from the pharmacist to nursing, in order to bring about the optimal patient outcomes that we want and ensure regulatory compliance. So continuous ongoing collaboration with your medical director on your gradual dose reduction strategies will greatly increase the likelihood of success. So here's a quick recap. So we discussed the definition of dementia. We talked about the umbrella of dementias. We went through the stages and disease progress for Alzheimer's disease. We talked about the psychotropics and that non-pharmacological interventions should always be the first line approach, and that adequate documentation for justification of use is important. And then we also talked about the consideration of psychotropic side effect profile and drug characteristics in the management of these agents, and to start low and to go slow. And then we went over how the potential harm may outweigh the benefit, particularly for the antipsychotics, and that use of these drugs in dementia is off-label. And this is why close monitoring and gradual dose reductions are important. And then we talked about how developing a strategy for gradual dose reductions with multidisciplinary involvement and individualized interventions will set you up for success. These are the references I used, and we'll have our final poll. So what potential barriers might hinder the successful implementation of gradual dose reductions? Would it be A, using data to identify residents and engage staff, absence of a standardized process, or C, collaboration between the hospital and facility, or is it D, all of the above? So we're looking for a barrier from these choices. Which one or which ones do you think would be a barrier to successful implementation of GDRs? Okay, so the answer is actually B, because we were looking for a hindrance to successful implementation. So absence of a standardized process is a huge barrier. That's why having a system in place and engaging everyone is really, really important. Using data is a good thing, so you can get an objective viewpoint of how well you're doing and sort of what psychotropics you're using, and collaboration between the hospital and facility is also a good thing. So all of the above wouldn't be correct. The correct answer is absence, having the absence of a standardized process. So with that, that wraps up my presentation. Thank you so much for your attention. And I hope you've learned a thing or two. Thank you so much.
Thank you.